Thank you, Dr. Marin, for that wonderful introduction. It's a tremendous honor for me to be able to speak to the department this morning. And it's very hard for me to believe that it's actually been 6.5 years since I started at Mount Sinai. It's been tremendous fun. I ranked this program #1 after I interviewed, and in retrospect, I think I ranked it too low because it's been more fun than I even thought it would have been. And while I'm very much looking forward to the last few remaining months I have, I'm going to be very sad to leave, I know, at the end of the year already. So thank you very much. I'm in tremendous gratitude for everyone in this room that's done anything to help train me. I think everyone has taught me how to operate, try to think about when to operate, when not to operate, but most of all, I think you guys have really tried to instill in me to think about what we do, to think about why we do it, and to always reevaluate, is there a way that we could do it better? So when I'm talking about this morning, please don't take it as anybody thinking I'm saying anything we do is wrong, but only that I'm thinking, is there a way we should do it better or something that we should reconsider in how we practice? So I'll talk quickly just about the objectives and dogmatic theory. I'll go on to list some practices that I think we observe pretty much every single day that I think are actually not well-founded on any type of evidentiary basis. I'll more intensively investigate 3 what I would contend are commonly held surgical myths, and then we'll conclude with some final remarks. So I want to emphasize, I'm not only promoting evidence-based medicine. I don't think that the literature answers every single question that comes up, and I really don't think there's any substitute for completely just sound clinical judgment in your approach. However, I do think trying to maintain an attitude of sound clinical judgment requires us to constantly be asking ourselves, is what we're doing based on evidence, is what we're doing for a reason? Can it be done better? Or is it just being done because it's what was taught to us by someone who trained before us who we very much respect? And I'll talk about some type of routine myths that I think are developed in our practice. So what is dogma? Dogma is nothing more than a belief or a teaching that's highly accepted, but most of all is meant not to be questioned, not to be challenged, not ever to be have the spotlight shown on it. And because of that, it's highly resistant to change. Now, why is this dangerous? I think one of our American historians named Daniel Borston actually put it quite eloquently why it's dangerous. He said, the greatest obstacle to discovery is not ignorance, but the illusion of knowledge. Meaning if we think we know something and we're convinced that we know it, even if it's not true, that's perhaps the worst type of scenario. So dogma to me is nothing more than not seeing the big picture. It's not being open to other ideas. It's like walking down a street with blinders on or driving a car with no mirrors, or in the case of this penguin, diving off the cliff without looking first to see what's in the ocean. So all I want us to do is to be open. Don't have any such belief that we're not willing to question and not willing to potentially reevaluate, because in some cases it may actually prevent us from giving better care to our patients. So I could have talked about many different things in this talk, and I just chose some examples that I thought were somewhat interesting. But I think there's quite a few practices that we see developed and performed every single day, things that I was taught as a medical student, that I was taught as an intern, and retaught as a resident. And I think if you go back to the literature, not only in many cases is there a real lack of evidentiary basis to support these laws of surgery, I think in some cases there's actually literature that would support completely the counter-argument. Now, I'm not even saying that any of these practices are wrong or that people who do them are evil or anything of that sort, but I do think holding so firm to them that we're not willing to question them is somewhat dangerous, because I think it can actually help prevent us from developing better standards of care for our patients. And I think if you look at the literature, you can just spend any number of minutes on PubMed and you can find hosts of different articles that are being published every single day or presented at conferences and meetings and developed that show that a lot of the things that we were taught to believe, maybe as medical students or interns, aren't necessarily true. And again, doesn't mean that we've done wrong by using them, but I do think it is wrong if we're not willing to at least rethink some of the, quote, rules or laws that we were taught in some time of our course of training. So all I'm trying to do is, again, allow us to be open. So I could have talked, again, about any of those things. I just chose 3. So being atelectasis as a cause of postoperative fever, the routine use of intraoperative peritoneal irrigation, and gradual refeeding as GI surgery. Again, all things I was taught as a student, intern, and resident, and all 3 of which I'd like to put in the crosshairs to see whether or not these are truly based in evidence. So we'll start with a case. This is a 52-year-old male who has hypertension, hyperlipidemia. He had a laparoscopic right hemicolectomy for cancer, and on postoperative day 1, he has a low-grade fever, 100.9. Vital signs are completely fine. Otherwise, he's relatively asymptomatic. But as part of a fever workup, he gets a chest x-ray. So we look at his x-ray, and sure enough, we can see what? Some atelectasis. So atelectasis is derived from Greek meaning incomplete expansion. It's more carefully defined as just collapse or closure of one or more segments of lung resulting in hindered gas exchange. So this is a well-known cause of fever. This is like the medical student's friend. If you don't know, this is the most common cause of early postoperative fever. You're not going to look good on rounds. Now, is this evidence? Is this based in evidence, or is this just an eminence-based belief? So the recognition of atelectasis really started in the early 20th century with the development of plain chest radiography. However, for about 5 decades, there really was no effort to distinguish between pneumonia and atelectasis. Yet in the 1950s, medical schools began teaching this as a cause of postoperative fever. And then in the 1960s, that's really made its way into our surgical literature. But is the literature based on anything? So I just looked at a pretty reputable text. So this is from the 2010 edition of Current Diagnosis and Treatment of Surgery. And they state very clearly in their chapter on postoperative complications, atelectasis remains an extremely common cause of fever within the first 24 to 48 hours following operation. That's pretty conclusive. So where'd they get this? They took it from Sabiston. So I went to Sabiston. I looked in the 2008 edition. Sabiston gives also a pretty firm statement. Postoperative fevers in the first 48 to 72 hours. During this interval, most fevers are believed to be caused by atelectasis. That's pretty concrete. So obviously they got this from some good source. Well, they took it from Schwartz. So I went to the Schwartz text from 1999. And they give also a very concrete statement. Atelectasis usually becomes manifest in the first 24 hours after an operation. They get even more descriptive. There's usually a sudden onset of fever and tachycardia. So surely we can believe that this is firmly based. Well, they took it from a paper, actually, in Archives of Surgery in 1973, published by Schlinker and his colleagues. So I looked at that paper. So I thought, surely this is where our foundation comes from. This is a paper entitled The Pathogenesis of Postoperative Atelectasis, a Clinical Study. They say fever, which often accompanies the other signs of atelectasis, suggests that infection is also present. So then I went to look at their data, what they based this on. They really didn't have any data. This was just a descriptive paper. Despite being called a clinical study, there really was no clinical study. But they based it on another source. So I looked at Lansing and Jameson. When I would contend, if you go back in the literature, this is actually the primary foundation of text that has instilled in us this belief that atelectasis causes fever. So this is also in the Archives of Surgery. Mechanisms of fever and pulmonary atelectasis, and they describe pulmonary atelectasis, a common postoperative complication, is associated with high fever, tachycardia, and a rapid respiratory rate. And this is in the introduction section of this paper, so they got it from somewhere, obviously. Only it doesn't look to me like they did. So I looked at their own data, and this is actually from the article itself. So what they did was they induced an atelectasis model in canines by occluding the left main stem bronchus. They then followed these subjects both radiographically and clinically, and eventually they sacrificed the animals for pathological analysis. And then they correlated fever with findings of atelectasis on imaging, as well as clinical signs. So these are really the critical figures on which they base their conclusions. And what you see here is on the graph on the left. They're showing both the heart rate, temperature, and respiratory rate over time. On day 2, they put in the plug in the left main stem bronchus. And as you see, there's a quick spike in the fever, also with the heart rate and the respiratory rate. Then they removed it on postoperative day, or I'm sorry, on 2 to 3 days later, and you see that the fever comes down, as does the heart rate and the respiratory rate. Now on the graph on the right side of the screen, it's the exact same experiment, but these animals were given antibiotics. And you see there's a very blunted response of temperature and heart rate. So they led this to conclude, well, atelectasis caused fever, and it was started when you put in the, when you occluded the bronchus. You give antibiotics, it gets better. However, I think the real problem with their conclusions comes not in their figures, but in their text. If you read these two segments of their text, I think they're fairly telling. They say, interestingly, radiographic evidence of atelectasis did not seem to frequently correlate with the findings of fever, tachycardia, and increased respiratory rate. In the animals that had no fever with antibiotic administration, microscopic examination of the lung showed complete atelectasis with inflammatory cell infiltration. Overwhelmingly, bacterial cultures of the lung tissue were found to contain pathogenic organisms. To me, what this means is that the animals probably had pneumonia, and that's probably why they responded to the antibiotics. That's probably why the fever was suppressed, and that's probably why many of these dogs did not have signs of atelectasis on their x-rays, because I don't think atelectasis was causing their fever to begin with. So if you don't agree with me on that, even Wikipedia will probably try to make my argument. If you just go to the Wikipedia page for atelectasis, go down to the section that says signs and symptoms, they'll even tell you very conclusively, it is a common misconception that atelectasis causes fever. And I think this is at least one instance in that non-medically trained lay persons are probably a little bit ahead of us as physicians. So, is there any data to argue the opposite, that atelectasis does not cause fever? And actually there is. This is a paper taken from the journal Chest in the mid-90s where they performed a single institution prospective study. They enrolled 100 consecutive patients that were admitted to the cardiac surgery ICU following elective cardiac operations. They followed them with temperature every 2 hours as well as daily x-rays, and they looked at the incidence of fever, incidence of atelectasis, and was there any correlation. So this is one of their data tables, which I think is a little hard to interpret when you just look at it quickly. So I kind of want you to zoom in on these two sections. The first red box is showing on day 1 the incidence of fever and the incidence of atelectasis. And what you see is that patients who had a fever over 38.5 were much less likely to have atelectasis on x-rays than their atelectatic counterparts. And then as a combined set from day 0 through postoperative day 2, you were statistically less likely to have fever if you did have atelectasis and vice versa. So if they even looked at the severity of atelectasis and how did this correlate. And I think the easiest way to look at this is graphically, which shows a completely inverse relationship in the incidence of fever and the incidence of atelectasis, such that as time went on, patients were much more likely to have atelectasis and much less likely to have fever. So do I think the atelectasis was protective? No. But I certainly hope you take away that it was by no means causative. So this is just one paper. Let's see, what else can we find? Well, just 2 years ago in the journal Chest, a meta-analysis was performed by a single institution to try to really answer this very question. They did an exhaustive literature search and performed a meta-analysis on all studies that really were highly investigating this claim. And they tried to investigate relationships between fever and atelectasis. They defined fever as above 38.0 and atelectasis as being based on radiographic diagnosis. Now, I think probably this slide is one of the strongest arguments I can give you that this is a myth. When they did their exhaustive literature search, they found about 390 articles. However, most were completely on a different topic. So then they cut those out. And then they began cutting out others that did not meet their minimum standard for inclusion. These were articles that were duplicated, articles that referred to another text but had no actual data, those that had inadequate data, inadequate follow-up, or, like I said, were completely irrelevant. Once they cut out all those articles, they were left with just 8 studies. Now, I would say, even if all 8 of these studies said atelectasis caused fever, is that really enough that you'd want to base one of our founding beliefs as in terms of postoperative care? I would say no. But even they didn't support it. They showed that if you looked at the sensitivity, specificity, positive predictive value or negative predictive value or accuracy, none of them met the threshold for significant inclusion as being a causative factor for fever. So if I don't believe that atelectasis causes fever, there must be some cause. We've all worked with patients who've had fevers on postoperative day 0, 1, 2, and then go on to have a benign postoperative course. So if we don't believe that was from an infection or a pneumonia, then or some other identifiable agent, it must have been from something. And there's multiple explanations, but I'm going to blame it on cytokines. And I'm sorry, yes, this is the only slide of basic science, so I apologize to those who don't like it. I won't name anyone in particular. But this is some data that I actually generated during my research fellowship. It was completely unrelated to atelectasis, but I do think it is relevant to what I'm talking about this morning. So we performed a series of experiments where we gave mice inhaled anesthesia, we opened the abdomen, and we inoculated the liver with tumor cells. Now, then we closed the abdomen and we followed them for certain marker expression and survival and so on. Now, what I'm showing you is not the mice that were injected with tumors. This was actually our control group. For these mice, we gave them anesthesia, we opened the abdomen, and then we just closed. We took peripheral blood from these animals before the operation and after the operation, and what you see here is a PCR-based superarray on marker expression. The top 3 rows are those mice before we did the surgical opening of the abdomen, and the bottom 3 rows are actually the exact same 3 mice and their samples after we'd open and close the abdomen. And you see differential marker expression from a host of different markers. Now, I just pointed out 4. And what you see here, green being upregulated, or high expression, red being relatively low expression, you see remarkable differential expression in the same animals for IL-6, IL-1, IL-1 beta, and TNF-alpha. And why are these interesting? It's because all of these, to some degree, are known to be pyrogens. So if you want to look at it in a graphical sense or numerical, again, what you just see is in the black boxes here, the black bars, are the postoperative values relative to the normalized preoperative values. And you see that for all 4 of these markers, and there's certainly others I could have shown, the upregulation of these factors was significantly elevated after just opening the abdomen alone with no other type of surgical intervention. So this is just data I generated. I wanted to look at, is this something that had been explored by actual qualified researchers? And it is, and it's actually not particularly a new idea. This is just one of multiple articles I could have shown, taken from the early 90s, where Wurtel and colleagues just drew peripheral blood from patients prior to undergoing an elective Whipple. There were 19 patients. They took blood before and after the operation, and then they followed the patients with measuring their core body temperature also before and after the operation. And what they saw was a significantly increased level of peripheral IL-6 levels after the operation compared to their preoperative values. 84% of the patients developed fever. And what they found is that the elevation in IL-6 temporally was highly associated with those fevers, with the increase in core body temperature, showing that it probably is due to the cytokine response in these patients. So again, this is just one paper of many that I think support this claim. And I certainly can't say that it is the absolute truth, but I think there's actually much more data to support this as the cause of postoperative fever than atelectasis. So I said I'm going to talk about 3 things. I'm going to move on to peritoneal irrigation. This is something that I've also been taught quite a bit. I've certainly heard this mantra from many people. The solution to pollution is dilution, right? Well, the origins of this, at least in the literature, go back to the early 1900s. There's an obstetrician named Joseph Price who advocated irrigating with sterile water to try to reduce contamination in the peritoneal cavity. Ritter, 2 years later, advocated irrigation with granular salt because he thought it would actually cause more of a purifying of the fluid that was in the cavity and contaminated. Then in 1911, Torek actually advocated using saline and showed, or at least stated, that it resulted in decreased mortality. Now, this was controversial for quite a while. Deaver actually advised against peritoneal irrigation, arguing that perhaps it actually caused bacteria or agents to spread throughout the abdomen to areas that would otherwise have been unaffected. And in 1926, Moynihan advised British surgeons to avoid using irrigation, mostly for the same reasons. But a lot of changing on this subject, or a lot of minds on this subject changed in the late 1950s when Burnett and colleagues published their results, which I'll get to. So I just looked first, is this really popular, or is this something that we just do, or do other people do it? And this was a questionnaire-based study that was done in 2005 in England, where they sent this questionnaire to 153 board-certified surgeons. They just asked them basic questions. Do you use irrigation in the peritoneal cavity? What type of fluid? Under what conditions? And so on. And these are their results. They got about 77% of surgeons to respond. Almost all stated that they used irrigation under at least some circumstances. About 1/3 stated they would use it in a clean case, but 90% and above said that they would use it in a clean contaminated, or infected case. By far, the most commonly used fluid was saline, although 2/3 of the respondents said they would use sterile water under certain conditions, and to a much, much lesser extent, diluted iodine or diluted antibiotics. So this is just looking at it in graphical form. Again, saline was by far the most commonly used fluid type, although in cancer surgery, sterile water was actually more popular. And you do see that there's an appreciable number, again, about 1/3 in total that would use it on a clean case, but it dramatically increases for any type of case more contaminated above that level. So I looked at some of the origins of this, and some of it actually come back to New York. This is a paper that was published in Annals of Surgery in 1906 by a surgeon named Dr. Lucius Hotchkiss, who worked at J. Hood Wright Hospital, which is now closed, but was later renamed Knickerbocker Hospital. This is on the Upper West Side of Manhattan. So he published a single institution experience of his results of all comers undergoing appendectomy, and obviously this is in the open era, of 114 patients. And for 4 years, 1895 to 1899, he did not use irrigation. At that point, he started using hot saline irrigation, and for the next 4 years, he compared the results, and did he see difference in outcomes? So he did. In 1895 to 99, before irrigation, he treated 42 patients with appendectomy, 11 of which went on to die. After that, he treated 72 patients, and he's now irrigating in every single operation. None of them died. And he didn't report any statistics, but if you do Fisher's exact test analysis, these are highly significant results. This was presented apparently at the New York Surgical Society, and is probably one of the most instrumental moments of making this practice be more widely adopted in the city, and which later on would be more widely adopted across the country. He states, the use of saline irrigations to the peritoneum, as described through the small lateral incision, does not consume much time, and seems by diluting the remaining fluids to hasten their absorption, besides acting generally as an intravenous infusion would to hasten the removal of toxins by dilution, besides stimulating the heart and circulation. Moreover, the actual ability of the peritoneum to cope with the inflammation seems to be increased and not hindered. Again, the solution to pollution is dilution. So I mentioned this paper because I think it's also one of the groundbreaking papers that instilled this as one of our core surgical practices. This was published by a group at Temple University in 1957 in the Annals of Surgery. This is a single institution experience where they eventually advocated using intraoperative peritoneal irrigation with aqueous antibiotics. So this was a two-modal study, both an assessment of their clinical outcomes in the 3 years prior to adopting irrigation and the 10 years subsequent to that adoption. And then they also did an animal experiment that we'll talk about. So they actually claimed that they had a 60% decrease in mortality for their cases of peritonitis, which is pretty critical. However, they don't actually give any of their statistics. They don't give the denominator. They don't give what cases were done. And I'm not saying I don't believe them, but it's a little hard to base, I think, this belief on just a sentence in text. So I looked at their animal experiments. And what they did was they took guinea pigs. They induced a sepsis model where they opened the abdomen, they injured the colon, and then they actually put them into several different groups. Some were just left open. Obviously, almost all of them died. Others were just closed with no treatment, yet others were closed with giving intraperitoneal antibiotics. Some were given systemic antibiotics, and some were given irrigation with saline and combination type treatments. And what they saw was a decrease in the mortality when they were treated with irrigation, with intraperitoneal antibiotics, and systemic antibiotics. Now, these are good results, yes, but they really don't have the proper control group if you think about what we do today, which is irrigation with systemic antibiotics. That's really the group that's missing. They also remark in the paper, I think, which is very telling, that they repeated this experiment several times and were not able to get the same results. So by their own admission, these are not reproducible results. And again, I would argue probably not something that we should base our entire practice on. But let's look onward. So they mention intraoperative peritoneal lavage with antibiotics decreases mortality in cases of peritonitis. And we talked about the weaknesses. This is retrospective analysis of their clinical outcomes, which we don't actually have any analysis with which to view. We have to take their word for it, so to speak. And one animal experiment that did not seem to be reproducible. So let's fast forward and look at something more recent. So this was actually a paper published from a group of surgeons in Virginia. They looked at all comers undergoing appendectomy for appendicitis at a tertiary care facility and retrospectively analyzed their results. They looked for both open and laparoscopic cases at 176 patients total, and they just noted whether or not intraoperative irrigation was used and what were their results in terms of postoperative organ space infections. So the groups were pretty well matched, at least in terms of age, symptom duration, and weight that they report. However, one factor that should be noted is patients who were treated laparoscopically were more likely to be treated with irrigation than their open counterparts, at least somewhat. So they note that they had an overall organ space surgical site infection rate of 7.4%, which is actually fairly on par with many other published results. They saw no difference whatsoever between open and laparoscopic cases in terms of the development of abscesses. They actually saw less patients who were treated without irrigation who developed the abscess than those who were treated with irrigation, although they weren't statistically significant. But this is just one retrospective study, and most importantly, there were different rates of perforation noted. So if you had a perforation, you were more likely to be irrigated. So it's a very confounding factor with this study, I will admit. So let's look at others. This is actually taken from a paper published just earlier this year from a group of 2 children's hospitals, and they looked in the pediatric population, those patients undergoing appendectomy strictly for perforated disease. They then assessed retrospectively their results, looking at superficial wound infections as well as organ space surgical site infections. Sorry that the table does not reproduce very well, but hopefully you can see the groups were pretty well matched in terms of age, admission white count, duration of symptoms, gender, and so on. So then they looked at their outcomes. They grouped patients into the suction only or suction and irrigation group. And the group that got irrigated, and again, this is all perforated patients, the group that was irrigated had a 5 times higher rate of developing a postoperative abscess and a 9 times higher rate of developing a superficial wound infection. And these were highly significant results on multivariate analysis. So just looking, and then they thought, well, perhaps we're just seeing the difference between open and laparoscopic surgery, and I don't really think that's the case either. So if you look on the right side, you see only the laparoscopically treated patients. If they were irrigated, they had a substantially higher rate of developing a wound infection and a substantially higher rate of developing an organ space surgical site infection. If you look at the left side, you see that the patients that were treated with an open operation, they also had a significantly higher rate of developing an organ site infection. The open patients that were treated with just suction did have a higher rate of superficial wound infection, although it did not meet the statistical significance with a p-value of 0.12. So then I thought, well, again, this is just retrospective. Is there any other better set of data that we can look at? And there actually is. This paper was published just last year in the Annals of Surgery. Again, this is in the pediatric population, where they looked at patients undergoing appendectomy for perforated appendicitis. They performed a randomized controlled trial at one institution where they randomized patients to be treated with appendectomy with suction only or appendectomy with suction and irrigation. For the suction-only patients, no saline bag was attached to the suction irrigator device. Then they looked at their perioperative outcomes, their development of intra-abdominal abscesses, which was their main endpoint, as well as some other findings. So this just shows that the 2 groups were actually very well matched in terms of age, weight, gender, duration of symptoms, and so on. When they looked at their perioperative outcomes, they really didn't see any differences except that the operative time was longer for patients treated with irrigation. It just barely missed meeting statistical significance with a p-value of 0.056, obviously trend towards significance. Now, when they looked at the patient's fever curves postoperatively, they saw no difference whatsoever between patients who were treated with suction only and those who were treated with irrigation, with the exception that on postoperative day 2, the patients that were treated with irrigation were more likely to have a fever, perhaps going back to that cytokine response that we talked about, but unclear. So then they looked at the development of postoperative abscesses, no difference whatsoever. And of the patients who did develop an abscess, the irrigation was not likely to make it any less benign or more or worse. So there was no difference in abscess-related cost, extra days spent in the hospital, and so on. They had another thought about, well, does the irrigation cause the infection to be spread to other parts of the abdomen? They really didn't see that. So they looked at the distribution of where these abscesses that developed were located based on whether or not the patients were treated with irrigation or suction only. Again, saw no difference. So at least their findings are that this is probably a procedure that's not indicated, at least in the setting of perforated appendicitis. And I would argue that although we perhaps cannot extrapolate these results to patients who are freely perforated to all quadrants of their abdomen, you can't answer that question from the literature. I do think we can think about whether or not this is true for any type of perforation that's localized. However, it's not answered by this study, and I can't point to it as definitive results. So they said there was no difference in time to diet resumption, length of stay, in-hospital costs, and most importantly, organ-space surgical site infection. It's limited by the fact that they did not analyze the development of superficial wound infections, so I can't tell you how that was impacted. So finally, I want to talk to you about something that's very near and dear to my heart, as anyone knows, and that's food. So I'm going to talk a little bit about how we treat patients in the postoperative setting in terms of diet resumption. Now, this is just a screenshot taken from Epic that shows several different patients and what diet they're ordered for. I covered up the patients' names to protect the innocent, and I covered up the attendings' names to protect the guilty. And what you see is that these patients are ordered for a variety of different diets. You have some that are NPO, some that are NPO but ice chips, others that are unclear liquids, full liquids, GI soft, regular. And the reason I picked these patients is because they all had basically the same operation. And I think it shows that there's a heterogeneity of opinion upon what type of orders we can give these patients after surgery. And despite the fact that we all are, I think, very well trained and think about this, we don't really seem to agree. So why is this important? Well, I was taught as a medical student, we gradually resume diets after surgery because we want to prevent nausea and vomiting. We want to prevent aspiration, certainly. But you also need to worry about over-distending the GI tract while the benign dysmotility associated with surgery and anesthesia are resolving. And most importantly, to allow time for GI anastomosis to heal. So we're just going to look a little bit on is there data about these. Well, in many respects, our colleagues in vascular surgery, urology, and gynecology are a little bit, I think, ahead of us in that there's been a multitude of reports from these different specialties saying that these patients can actually be given regular diets on post-op day 1. Now, all of these studies I'm showing you are patients who underwent major intra-abdominal surgery. This is surgery on the aorta or bladder, ureter, kidneys, or uterus. And they looked at their outcomes as to whether or not these patients were given regular food or whether they were kept in PO and then gradually given a diet as they resumed bowel function. They saw no difference whatsoever in mortality, no difference whatsoever in morbidity, and in some cases they actually showed decreased morbidity, such as after a total abdominal hysterectomy or cystectomy, having decreased risk of superficial wound infections if they were fed immediately on post-op day 1. But this is easy for them to do, right? They don't operate on the GI tract. Maybe there's some manipulation of the bowel, but they don't really operate on the GI tract, and they certainly don't have a GI anastomosis that they're trying to heal, which we do. So maybe you can't take these results and change our practice. So then I looked at really just within general surgery. This was a meta-analysis published in the British Medical Journal in 2001, where they took 11 randomized controlled trials to patients who were undergoing major GI surgery. These were all patients who were randomized to receive regular diet on post-op day 1 or kept NPO with the gradual resumption of their diet, much akin to what we typically do, I think, more commonly. And in total, they had over 800 patients that were included in their analysis, and this spanned from the late 70s to the late 90s. And this is just a table showing the basic characteristics of the trials that were included. I just put this up there so we could see what type of operations that these patients have. If you look over here on the very right side of the table, you see most of them had surgery on the lower GI tract. There were some that had procedure on the upper GI tract and some hepatobiliary, but mostly on the lower GI tract. So that is important to keep in mind. Then these are their results. So a very busy table, yes. I'll just sum it up that they saw that there is significantly less risk of anastomotic leak. They saw less risk of anastomotic leak, any total infection, superficial wound infection, pneumonia, intra-abdominal abscess, or mortality for the patients that were fed immediately. They did, however, see increased rates of vomiting. So that's important to note, but not increased rates of pneumonia. Now, these are just their reported results, so let's look at it in terms of statistical significance. So this is an association type graph, and what you see is any bars that fall on the left side tend to favor giving regular food on post-op day 1. Any bars on the right side favor keeping the patient in PO and gradually resuming their diet. So with the error that's factored in, there's really only 2 findings that met pure statistical significance. And that was that there was decreased risk of altogether surgical site infections and increased risk of vomiting if you gave the patients regular food on post-op day 1. Other findings did not quite meet significance. However, if you look at things such as anastomotic dehiscence, they came very, very close to meeting significance and towards favoring the group that was fed on post-op day 1. So while it didn't meet significance, I can't say that it's better to give these patients regular diet. I can definitely feel like I can say it's not worse. And it's not such an absolute crazy idea. So they concluded that immediate postoperative feeding is well tolerated after major GI surgery. There's actually decreased total development of surgical site infections, but certainly no increase in appreciable morbidity or mortality. But there's weaknesses. It's a meta-analysis. It's combining multiple trials, non-uniformity of treatment, non-uniform follow-up, heterogeneity of operations, all things you have to factor in. And probably most importantly, this study is not really focused on patients who had upper GI surgery, because we all know, or we've all been taught, that if you have a patient that has had upper GI surgery, they have a proximal anastomosis, you have to even be more conservative with them because they have such a proximal issue. Whatever they eat is going to go across that anastomosis immediately. So, at least we know that that's one confounding issue. Or do we even really know that? This is a study that was published just 5 years ago in the Annals of Surgery. This was a randomized controlled trial from 2 institutions in Europe. And what they did was they took all patients who were undergoing major surgery on the upper GI tract only. They then randomized these patients to undergo immediate regular diet on postoperative day 1, or to be fed through a enteral feeding tube placement, either a gastrostomy tube or more likely a feeding jejunostomy tube. We'll talk about why that's maybe relevant. So they included adult patients undergoing major upper GI surgery who had at least some appreciable life expectancy. They looked at their major postoperative morbidity, reoperation rates, and obviously mortality. So this is just showing the baseline characteristics versus feeding with enteral tubes versus normal food immediately after surgery. And the groups were very well matched in terms of age, preoperative weight loss, their nutritional status as it being measured by their preoperative albumin or nutritional risk index, as well as whether or not the patients were undergoing an emergency or elective operation. So what operations do these patients have? It's quite a varied group. So you have some patients who had a gastrectomy, Whipple operations, hepatic resections, esophagectomies, and so on. So it's important to keep in mind not all one type of operation, but all confined to the proximal portion of the GI tract. Now these are their outcomes, a ton of numbers. I know it's very hard to read, sorry, so I will just focus you on really what were the only 2 significant findings in terms of differences. They saw that patients who were fed with regular food on post-op day 1 actually had a lower risk of myocardial infarction and a lower total number of postoperative complications. Otherwise, the results were no different. Now, one thing to keep in mind is that the control group in this study, in my opinion, is not really our standard of care here in the United States. They very clearly used feeding gastrostomies and feeding jejunostomies, I think, more aggressively than we do. So that is important to keep in mind when you're looking at differences between two groups. And it's a confounding factor when you look at their results and trying to extrapolate them to what we do in the US. But I would contend that perhaps it's not as big a confounding factor as you might think, only if you think about it like this. What if I just covered up these two columns and we just looked only at the results of the patients that were given regular food on post-op day 1? I would ask you to ask yourselves, are their outcomes really different than ours? Is a 5% rate of postoperative SIRS in this group really different than what we have now? Is a 1% chance of short-term bowel obstruction different? Or a 3.5% chance of postoperative sepsis? Again, I can't say that these outcomes are better, but I would contend they're certainly not worse, and that maybe giving these patients a regular diet immediately is not such a crazy idea. So in conclusion, I do think surgical dogma is very common, very pervasive. It doesn't matter where you practice, if it's rural or urban, academic institution, at the cutting edge of new surgical innovation, perhaps even on the Upper East Side of Manhattan. I'm just showing you 3 examples. Again, I could have talked about a whole host of examples that I put on the list early in the talk, but it's not really even about the examples that I'm showing. It's not, to me, trying to convince you that atelectasis doesn't cause fever, maybe a little bit. It's just trying to convince you that we should always be open-minded to rethink what we thought was law, that the things that we're taught in training are not carved in concrete. They're on a whiteboard, which can always be erased and perhaps advanced. But if you're not having an attitude of healthy skepticism, then you're not going to be open to those changes. You're going to be rigid and set in your ways, and I certainly fall prey to that just as much as anybody else. But it's important for us to always keep that attitude as we're practitioners so that we can know that what we're doing is not necessarily the best we can do for our patients, it's just the best that we were taught at that time. So in conclusions, I want to thank several people, including Dr. Davino, who I will always be indebted for picking me as a resident in this program, as well as anybody else who's on the admissions resident committee, Dr. Marin for being such a supportive chairman, for allowing me to pursue both my clinical and research interests. Dr. Mark Goslin was a radiologist at Oregon Health and Science University, where I went to medical school, who challenged all of us who took his elective course to be on the lookout for dogma regardless of what field we eventually matched into and pursued, and always be willing to challenge that both in our heads and vocally if we think it was indicated. To my parents, Paul and Carlos Coakley, who I thought were the best parents I could have ever asked for and supported me in all of my endeavors. To my wife, Seema, who I couldn't even begin to describe everything that she has done for me to get to this day, including being my rehearsal audience last night. And to all of my attendings who have done anything along the way to help train me, I will always be in your debt and I'll always be thankful. And I look forward to working with you for the rest of this year. Thank you.